Hello everybody, good afternoon. Welcome to this channel, to another nursing channel. I know there are so many nursing channels out there in YouTube, but what makes our nursing channel a little bit unique is that we will talk beyond what the basics are in terms of nursing. So in this channel, you can expect that we'll be talking about some clinical skills, clinical events. We are also going to be talking about NCLEX topics for those of you who are studying for their NCLEX examination. We're also going to be talking about evidence-based practice, especially for those nurses who are currently practicing. So I hope you like our channel, and uh, if you could subscribe to our channel, we will give you a PDF copy of this PowerPoint presentation as well as question and answer, especially for those who are preparing for their NCLEX examination. So today we will be talking about hyperkalemia and what the nurse needs to know about hyperkalemia. So just like in nursing process, we start with assessment. So potassium levels are normally uh, ranging between 3.5 to 4.5. Now, I must say it depends on the hospital policy because this number varies from one institution to another. So please look at your hospital policy in terms of the normal range for your potassium level. Anything higher than 5.0 is considered hyperkalemia, and anything higher than 6.0 is considered a life-threatening hyperkalemia. This is where we really need to do an immediate action. Usually at that level, we'll see some paralysis, and we're also going to see some major cardiac events such as ventricular tachycardia or BFib. Now, what are the causes of hyperkalemia? So I categorize the causes of hyperkalemia into three major categories. The first one is secondary to increased potassium intake. Second is intracellular shift. And then the third is the impaired potassium excretion. So we start with the increased potassium intake. Now usually this is very uncommon in adults with normal kidney functions. We only see increased potassium intake, especially from the food products that we use for those patients who have kidney diseases. Now, what are those foods that have high potassium content? As you can see, beans is number one. We have spinach. We have fruits such as oranges and mangoes and bananas. Those are some of the food products that we have that has high potassium content. Also, I must take into consideration that there are some IV fluids that have high potassium content in it, right? We know that in our current setting in the hospital. Now, this high potassium containing fluids may be in the form of a TPN. Some of the potassium sparing medications have high potassium content in it. And then usually there is a possible increase in potassium secondary to massive blood transfusion. So the second major cause of hyperkalemia is secondary to intracellular shift. As you can see in the picture on your right, the round portion at the middle is denoted is the intracellular component, and then the yellow portion outside are the extracellular component. Potassium usually likes to stay inside the cell, and then sodium usually stays outside the cell. So these are the two major cations. We remember that in nursing school when we say cations, they have positive signs, right? So potassium and sodium are brothers and sisters. Potassium live inside the house, I should say it like that, and then sodium lives outside the house. There is always equilibration for homeostasis to occur. So certain conditions such as DKA, such as hyperosmolar non-ketotic acidosis, such as sepsis can trigger an intracellular shift of potassium. So instead of staying inside the cell, the potassium tends to sip out of the cell and stay extracellularly. That's where we find our hyperkalemia, when we have too much potassium outside the cell. The other major cause of hyperkalemia is impaired potassium excretion, and usually it's secondary to acute and chronic renal failure. So in the picture that I'm showing you here, I'm giving an idea on how potassium are reabsorbed into the system, how they are secreted back into the lumen. So these are the lumen. So these are nephron, by the way, and these are our tubules in each of the nephrons. There are many tubules. So you have proximal convoluted, you have the thick ascending, and you have the thin, of course, loop of Henle. You have the convoluted tubule here, which is the distal portion, and then you're going to have the collecting duct, and then you have, of course, where we go, the urine goes to the bladder and being excreted out of the body. So in terms of reabsorption, potassium are reabsorbed in the proximal convoluted tubule, distal tubule, and the thick ascending, and they are being secreted back into the lumen. So the fluids in the lumen here are considered pre-urine, and potassium is being secreted back into it, whereas 100% of the potassium is excreted by the kidney through the bladder via the form of urine, right? So patients who have acute and chronic renal failure will have issues with potassium excretion. Hence, there is a possibility that they're going to end up with hyperkalemia. So just like in nursing, we would like to know what are the clinical signs and symptoms of hyperkalemia. First thing that we will notice would be muscle weakness, and it's better to monitor their calcium level because hypocalcemia can actually worsen the condition of hyperkalemia. So hence I suggest that we monitor, as nurses, we monitor calcium level for this patient as well. The weakness may worsen to paralysis, and then we see some EKG changes associated with hyperkalemia. As you can see, we are very familiar with the peak T wave when we talk about hyperkalemia. The other the other EKG changes associated with hyperkalemia is the depressed ST segment. There is also a wide QRS complex, and then you have a prolonged PR interval, and then at the same time you have a very flat P wave. Sometimes it's not discernible in the EKG, and then there is decreased R wave amplitude. Together with that, it's better to also look at the BUN and the creatinine level, and the reason why, because you want to make sure that the renal function of the patient is good. So just like in the nursing process, the next step is we do our diagnosis, and in order for us to determine our nursing inference or nursing diagnosis, in order for us to make the diagnosis, we need to have the data available for in front of us, and this can be obtained using patient history, the clinical signs and symptoms that we had, the laboratory values that we have, and the EKG changes that we have, and then we're able to identify the problem. In our case scenario, our problem is elevated potassium level, as evidenced by all the clinical symptoms and the data that you have collected. So that's our diagnosis. The next part in our nursing process is what we call planning. So in planning, there are 3 things that we want to make sure that we could do for our patient. First is we want to maintain hemostasis. And then second and third is to prevent the worsening of the signs and symptoms of hyperkalemia, and at the same time prevent cardiac arrest. The next step in the nursing process is implementation. Now, I categorize 3 different components of implementation for hyperkalemia. All the interventions that we know in nursing school and all the interventions that we know in the clinical setting, I categorize it into 3 major categories. The first one is the management of the EKG derangement, in which case we can use calcium therapy for that. The second component is the transport or redistribution of potassium back into the cell. And there are 3 things that we could do that you could expect the intensivist or the physician will order. the administration of intravenous sodium bicarbonate, insulin IV, and D50 IV as well, and then the use of albuterol nebulizer. And then the third major component is to remove this potassium from the body using Kayexalate, administration of Lasix, and of course hemodialysis. So let's start first with calcium. Now, I consider calcium therapy as the first line treatment for life-threatening arrhythmias. We want to do it quickly because this works pretty fast. There are two common calcium therapy that is available in the hospital setting. One is calcium gluconate, which is commonly used, and calcium chloride, which is also used in the hospital. Just note, however, that calcium chloride has more elemental calcium in it than calcium gluconate. However, because it's very irritating, it has to be given via central lines. Now, I'm not giving the dosage for these drugs because each hospital has different recommendations. So I would ask you guys to refer it to your hospital policy. Why do we give calcium gluconate or calcium chloride? What it does is calcium increases the threshold potential, thereby stabilizing the myocardium. So note, in this situation, calcium is not removing or reducing the amount of potassium extracellularly. What it's doing is actually stabilizing the myocardium, so it's preventing it from being irritable. So in situations wherein you have hyperkalemia, there is a tendency you're going to end up with either bradycardia, severe bradycardia, or even VTAC or ventricular fibrillation. Giving calcium gluconate or calcium chloride will prevent that from happening. Okay? So the next treatment is sodium bicarbonate. Now, this is very controversial. There are many studies that said it's not effective, and there are some studies that says it's effective. Now, in those studies wherein it's effective, administration of sodium bicarb is only effective if there is severe metabolic acidosis. So your sodium bicarbonate level, your bicarbonate level should be less than 17 milliequivalent. Now, why do we do sodium bicarb? So the mechanism of action for sodium bicarb, it stimulates the hydrogen and potassium exchanger, which transports or redistributes potassium back into the cell. Again, I'm not giving the amount dosage for the drug because it depends on the hospital policy, and of course it depends on the patient. The other therapy is the combination of IV insulin and IV D50. Now, insulin is given because it drives the potassium back intracellularly, and then D50 is also given to prevent insulin-induced hypoglycemia. So they're given in combination. The other treatment therapy is albuterol treatment, and this is actually given by an inhaler. And the reason, so albuterol is a beta-2 agonist, and the reason why it's given because albuterol again shifts the potassium back into the cell via this sodium potassium pump that you see in the screen, and it's given via inhaler, so it's actually really less invasive than any other of the procedures that we have. The other treatment modalities many of us are very familiar with is Kayexalate. Now, Kayexalate is a sodium, so it is either given PO or rectal, and we're familiar with the enema that we give in our patient. This is not considered an emergency drug because it takes at least 2 hours before it works, sometimes days if you give it PO. So this is not an emergency drug. The way it works, it binds, so sodium binds to the potassium in the gut, then it's excreted. Now, older versions of Kayexalate have 33% sorbitol in it. In 2011, the FDA changed the label to include warnings on the use of sorbitol because it can cause intestinal necrosis. Hence, many of the Kayexalate product that we have right now are sorbitol free. The next intervention that we're very familiar with is Lasix, right? And of course, this is to excrete extra potassium from the body. This is also given in combination with thiazide diuretics. Again, I'm not giving the dosage. Sometimes you give 20, sometimes you give 40, depending on the patient's condition. Lastly, hemodialysis. If the pharmacological therapies fail, all of this fail, then hemodialysis is the next choice. Now, there must be a vascular access, so therefore if the patient doesn't have one, then somebody has to access one, has to put one in, right? The good thing about hemodialysis, it really drastically drops the potassium by 1 milliequivalent for 60 minutes of hemodialysis. So this is really pretty effective. It's also going to be good for patients who are really very sick. There is such thing as CVVHD, wherein it's a very slow hemodialysis kind of thing, and it's usually very effective for patients with hyperkalemia. So finally, as part of the nursing process, we do evaluate our intervention. So the first thing, especially with hyperkalemia, we want to evaluate, or we want to monitor our potassium level, and of course determine the vital signs. We have to be very vigilant as nurses. We need to be very vigilant on what we do, and we have to continuously reassess our patient. So hopefully this helps. This is our first video. Let us know. Please subscribe to our channel. Like I said, we will give you a copy of this lecture. At the same time, there are some questions that you can use for your NCLEX exam if you're studying for your NCLEX exam. Thank you very much. I'll see you again.